Well, you may proceed, Dr. Shah, with your testimony. Good morning.
Good morning. I'm a pediatrician, and I'm representing the District of Columbia chapter of the American Academy of Pediatrics. So the American Academy of Pediatrics is a 64,000-member organization across the nation of pediatricians. Our DC chapter has over 400 members of pediatricians, pediatric residents that work in hospitals, clinics, and school-based clinics. So we currently have an infant mortality crisis. Some wards in DC, as you mentioned, the infant mortality rate is 14 in 1,000, which is one of the worst in the nation and double the national average. And these aren't just numbers. These are families and communities that are devastated. I had a family recently I cared for who lost their daughter at 2 months of age. And they were excited about their firstborn, their first daughter, despite the obstacles they face. And their obstacles are the same obstacles that many of the families I care for, including poverty, child care access, family support, parents struggling with tobacco addiction, and affordable housing. But all those things are beatable once you have the motivation of a newborn. But one night, the unthinkable happened, and when the parents and the infant were sleeping together in their bed, in their small apartment. So we think the Safe Sleep Act of 2015 is an important first step in trying to prevent tragedies like this in the district. This bill will guarantee that parents will receive the vital information about safe sleep before leaving the hospital. Before moving forward, I just want to go over a couple facts for everyone to understand. The risk factors for sudden infant death include co-sleeping with the infant in your bed or sofa, which account for almost 80% of the infants that die here in the district, as well as sleeping position, face down versus face up, head covering and bedding, and smoking exposure. African American babies are 2 and 3 times more likely to die from SIDS than Caucasian babies. And like most pediatric illnesses, sudden unexpected infant death disproportionately affects the poor. In DC, wards 5, 7, and 8 have the highest rates of infant mortality, 10 times more than Ward 3. So given the depth and complexity of this problem, the question is, will this bill make a dent in what we're trying to address? The evidence clearly shows that education by a healthcare provider can reduce SIDS deaths. But the jury is still out on the commitment letter and whether that is actually efficacious. We at the DC chapter of the American Academy of Pediatrics are supportive of this bill, but also believe the council should consider additional thoughts and a broader view. For example, I think it will be important to study the effectiveness of this bill on safe sleep practices, something that we would be happy to facilitate and contribute with. And then going back to the family I cared for, the bigger problem, there are other problems than just telling them about safe sleep practices. How are you supposed to have your baby lay face up in a crib when you can't afford a crib? People in poverty, so again, poverty is interconnected with this issue. People in poverty smoke twice as often than those that aren't in poverty. Again, another significant risk factor for an infant having sudden death. So overall, we believe this legislation is an important, vital step at tackling the staggering level of infant mortality we have in the district. But to solve this problem, we may need a broader, multi-dimensional approach, because that's exactly what our children and families are counting on. Thank you very much.
I thank you for your testimony. I'll reserve my questions until the entire panel has spoken. Dr. Shah, I can begin with you. What hospital, are you working at a hospital?
Yes, so I'm the pediatric chief resident at Children's National Health System. I'm here as my capacity as the DC chapter of the American Academy of Pediatrics.
Okay, several of you mentioned smoking. Is that a role, what role in prenatal care plays a role with SIDS?
So it's actually twofold. So evidence shows that smoking while pregnant increases the rate of sudden unexpected infant death, as well as smoking after birth. And I think the terminology, just to take a second, is kind of confusing and strange, because we have sudden unexpected infant death, we have SIDS, sudden infant death syndrome. The definition of SIDS is unexpected death that after a full review, there's no cause found. So oftentimes, that was the case before we had more science, more evidence that shows, oh, it's actually suffocation. Oh, it was unintentional, like co-sleeping causing suffocation. So I think this terminology often causes confusion among parents because they're saying, how can you prevent something that you don't know what happened with SIDS? So I think what we try to use the terminology is just, it's a sudden, unexpected infant death, and there are ways to prevent it, and sometimes you can't prevent it, as in SIDS, but often there are, and it's somewhat kind of the three big factors are co-sleeping, so with bedding, prone sleeping, so sleeping on your face, on their face, smoking, and also prematurity. So if you have a couple of those factors, then the infant can't regulate themselves to get out of that situation.
And just curious, does Children's Hospital, I don't know if any hospitals, and I'm thinking with our homeless population in the district, and I know that a lot of, I've noticed, especially at DC General, a lot of young mothers at the shelter. And I can imagine, I don't know, I think the shelter provides cribs, but I'm wondering, are there any hospitals that provide cribs, or would you ask a patient what they're living, you know, what home environment are they going to? Is that a potential question?
Yes, I think that, and that's a very important question. My clinical time is at the Children's Health Project at the ARC, in Southeast DC, and that's the social determinants of health. That's a very big question we ask. At Children's, we have a program for car seats as well, giving car seats, and then we have social workers and different community service providers that we're connected with. So if we identify a family that doesn't have a crib and needs that, we could provide the services they need to get that crib. But that's, again, just in the children's network in which we cover a lot of patients, but there's still so many people and so many places that don't have that resources. So we try, anytime we see a problem, we have the services to connect them.
And so for prenatal care, the main thing as it relates to SIDS is no smoking?
It's no smoking, and then the idea of preventing prematurity. So there's multiple factors that go into prematurity, including smoking, alcohol use, great prenatal care, and then just social stressors as well. So as I mentioned in my testimony, once we take a bird's eye view, it's almost everything in a person's life is really affected. But yes, preventing prematurity and smoking, I would say, are the two big indicators.
And so would you say the brochure that Children's Hospital has produced, is this sufficient for hospitals to use this universally across the board?
I mean, I'm not a doctor, but I think we have a very, very comprehensive sleep and safety tips that could at least be a really good starting point for those who will evaluate what the ultimate, brochure would look like. Ours is a one-pager, so I don't know if you want to take a look at it.
And actually the person who developed, so I would say it is almost like the gold standard, because the person who developed this, Dr. Rachel Moon, is probably the forefront thought leader on sudden infant death, and she was the one pioneering the efforts at Children's. So I would also agree. I think this is probably the level that you would want.
So this should not only for newborns, but even during pediatric visits, you say up to a year?
A year,
1 year, yes.
And what is it after a year?
Then we start talking about a couple other things as well. But after a year, for sudden infant death, the year is under a year is basically the times where we see it, and months 2 through 4 are the highest risk.